Hello everyone, my name is Dr. Priti Anand and today I'll be covering few important questions related to benign and pediatric gynecology. So just starting with a small quote, keep your energy focused on your goals and your dreams. Okay, so whenever there is an EMQ, always remember that you have to read this lead statements. Okay, so according to them, they are saying that there are clinical descriptions given. What is the most likely diagnosis in each one of the following? Okay, so for all the questions, there will be 3 questions related to one EMQ, and you have to, for 3 questions, they will be asking you the diagnosis. Okay, so there is a 15-year-old girl who is come for the evaluation of absence of onset of menses. History indicates she experienced a growth spurt at 11. Breast and pubic hair development began around 3 years ago. No other medical condition, takes no medication. She is not sexually active, no history of cyclical abdominal pain. Breast and pubic hair stage 4, which according to 15 is okay, appears to be of appropriate height. Per abdominal, there is a pelvic mass which is seen, and vaginal examination shows that there is a bluish bulging membrane. So, cyclical abdominal pain usually will be a finding whenever there is a MRKH syndrome, whenever there is a outflow tract obstruction. Okay, so might be she was having some sort of cyclical pain, but she was not able to perceive it very correctly. Okay, that might be one of the conditions, but usually whenever there is a outflow tract obstruction, which is seen in this condition by vaginal examination, there will be a cyclical pain. Okay, so might be there is something which she was experiencing but not able to tell you. Now, because pelvic mass is seen on examination and there is a vaginal examination which shows a bluish bulging membrane, so there is some outflow tract obstruction. And for this condition, usually the condition is imperforate hymen. There are 2 conditions where there is outflow tract obstruction and there will be the bulging of membrane, vaginal membrane may be seen. One is bluish bulging membrane, which is considered to be a cause is the imperforate hymen. And if there is a pinkish bulge, then it is basically a transverse vaginal septum. All her secondary sexual characters are normal. That means she is appropriately having the good hormones in her body. That is, the ovaries are working normally. Now, moving on to the second part, 17 years old Sarah. Again, she's come for the evaluation of menses. Breast pubic hair development started 5 years ago. So growth spurt at 11, no other medical condition, no cyclical pain, but she is sexually active, no medications to take. Breast and pubic hair is 10R stage 5, which is appropriate for age, good height, PA is normal, per abdominal is normal, local examination is normal, per rectal uterus is felt. Investigation shows she has primary amenorrhea, very low levels of LH and FSH, progesterone are high. Now, if the LH and FSH is low and everything down below will be low, then means that the patient has hypogonadotropic hypogonadism and the resulting in the primary amenorrhea. But here there is a picture is something different. The low pituitary hormones and the high ovarian hormones with the high prolactin and being sexually active and 17 years old girl. So these patients very rarely can be pregnant before the onset of first episode of menses. Okay. So if you look into the hormone profile, you will clearly make out that these are the pregnancy hormones, pregnancy related changes in the hormonal profile. Okay. The third part of the same question is a 15-year-old for evaluation of, again, primary amenorrhea, growth spurt at 11, development of pubic and sexual hairs by 3 years ago, no medical condition, no medications, not sexually active, pubic and axillary hair normal, 10R stage 4, appropriate height, PA, no mass, vaginal inspection, blind ending vagina, and ultrasound shows absence of uterus. So whenever there is absence of uterus, we have to consider, because the ovaries are working normally, so the secondary sexual characters are normal. But because there is an absence of uterus, it clearly indicates that the patient is suffering from MRKH syndrome. And definitely the patient will have no menses. So any patient with primary amenorrhea, first thing you have to see whether the patient has secondary sexual characters or not. If they are not there, that means the ovaries are at the fault. So you need to do the hormonal profile. If the secondary sexual characters are there, that means the uterus is at the abnormal level. So you have to do a pelvic ultrasound to see whether the uterus is present or absent, or there is an outflow tract obstruction. Okay, so moving on to another question, which says that what will be the next step in the management of the options from the options given below for the clinical description given. So 14-year-old girl came for the absence of menses, growth spurt at 11, breast and pubic hair development started 3 years ago. She has no medical condition, no medication she's on, not sexually active. There is no history of cyclical abdominal pain. Pubic and axillary hair, 10R stage 4, appears appropriate for height. PA is normal, local examination is normal, and you can feel the uterus on rectal examination. Okay, so everything is normal in this patient. So what evaluation you will do for this patient? Look, for the patients who present with the primary amenorrhea and they are having no menses and no secondary sexual characters and they are more than 14, then they are considered as a case of primary amenorrhea. Or if the secondary sexual characters are present, but the menses have not happened for more than 16, when she has reached 16 and above, then these patients are considered as a case of primary amenorrhea. Right now, she is still 14 with well-developed secondary sexual characters, but definitely there is absence of menses. But we can wait till 16 years, right? So in this patient, because examination is everything is already done and is normal, so she'll require no treatment, no investigations, no management right now, only reassurance. Okay, so you have to know that in our staging for the female development, and you have to also know the differential diagnosis of the various causes of the primary amenorrhea, whether it is MRKS, CAH, AIS, POI, or it is Swyer or Turner syndrome. Okay, remember, any patient which comes for the primary amenorrhea, first thing is to see the secondary sexual characters to confirm whether ovaries are working normally or not. Okay, and these flow charts will definitely help you to come to the differential diagnosis of the various primary amenorrhea cases. Okay, now my next set of question is basically related to choose the most appropriate management option from the list. So if you can see, there are all management options, whether it is a treatment options are there or the surgical options, medical options are there or the surgical options are there. So there is a 52 years old woman, para 3, BMI 32, presents to her practitioner with irregular vaginal bleeding. Transvaginal scan demonstrate endometrial thickness of 14 mm. Histology on outpatient says that it is a hyperplasia without atypia, no cellular atypia. So abdominal and pelvic examination is normal apart from grade 1 cystocele. Okay. So otherwise she is okay with regard to any other medical condition, and our examination also relieves nothing significant. But the most important thing, she is a hyperplasia with the irregular vaginal bleeding. Still no atypia is there. So how we will manage her? Because biopsy is already done, which is a primary requirement. So if now the hyperplasia is present, the treatment for this patient will be the medical management, because there is a 85 to 99%, 100% chance that with the use of the LNG-IUS, which is a first line management for the hyperplasia, the reversal is seen. The patient goes back to the normal endometrium. Okay, so the first line management for this patient is LNG-IUS system, Mirena, and these patients will be put on follow-up. Same set with the EMQ. What will be the management in this case as well? So 51-year-old underwent insertion of LNG-IUS 2 years ago for menorrhagia. 2 weeks ago, she attended the gynecological clinic with heavy bleeding. Okay, from the previous 2 months. You performed a biopsy at visit. You are now seeing her to discuss the histology result, and it shows a complex endometrial hyperplasia with atypia. She has no other past medical history, not taking any medications. What is the appropriate management? Now, she received LNG IUS for menorrhagia in the past, but from last 2 weeks, she is having, from 2 months, she is having some problems with the bleeding. So the biopsy was done. So the primary requirement has been fulfilled. And now it is hyperplasia. The endometrium shows hyperplasia with atypia. We can't leave the patients who have atypia. For the patients who have atypia, we should always and always offer them surgical options. Okay, so this patient will undergo hysterectomy with bilateral salpingo-oophorectomy because she is in the age group of postmenopausal age group. Okay, 51 years is considered as a age of postmenopausal in the UK. So these patients, you have to not do salpingectomy. Premenopausal, you have to do salpingectomy with hysterectomy in atypia cases. But for the postmenopausal ladies, we do a bilateral salpingo-oophorectomy. So this is the flow chart of endometrial hyperplasia, which shows that if there is a hyperplasia without atypia, the medical management is the first line, which is LNG-IUS system. Once you have given them LNG-IUS, you have to definitely put them on follow-up for endometrial biopsy every 6 months. After 2 negative biopsies, they are discharged from follow-up. They can retain the LNG-IUS system for a long time. If you want, they can remove it also. In the case patient has a high BMI of 35, or in case she refused LNG-IUS in the start and you have treated her for oral progesterone, then after 2 negative biopsies, every annually they have to undergo the follow-up for the biopsies. Okay. And for the patient with atypia, they have to always be treated by the surgical options. Bilateral salpingo-oophorectomy for the patients who are postmenopausal, and bilateral salpingectomy for the patients who are premenopausal. Okay, now my third set of EMQ is for the most appropriate next step in management from the options given below, above. So 55-year-old postmenopausal women presents with the general gynae clinic with a gradual distension of abdomen for the past 6 months. She is then referred to the consultant-led care clinic for suspected ovarian cancer. On ultrasound scan, it is revealed that it is a large multilocular mass. Her tumor markers, see how high her CA-125 level is. CA is okay, 19.9 is also okay. Now, because she has an ovarian mass with CA-125, first of all, our work is to calculate a RMI score for this patient. Okay. And her RMI seems to be more than 200. Now, because her RMI is more than 200, the first thing is you require to do a CT scan and ongoing referral to the cancer center. Now, because the two options are not together given in this patient, so first thing what we require to do is a CT scan. So the correct answer is CT scan, but the best answer for this patient is CT scan with ongoing referral to the cancer center. So any patient with the RMI of more than 200, you always and always do a CT scan with ongoing referral to the cancer center. 42-year-old lady who is seen in a general gynecology clinic with the symptoms of pelvic pain from 2.5 years. She has been treated for endometriosis 3 years ago with laparoscopic laser ablation. So the next question in the same set of EMQ is a 52 years old lady who is in the general gynec clinic with the symptoms of pelvic pain for the 2.5 years. She was treated for endometriosis 3 years ago with laparoscopic laser ablation. Now the ultrasound scan shows a right ovarian cyst of 8 centimeters with internal echos with the one thin internal septa. C125 is raised, which is 71. Now, if you see that the patient is in a premenopausal age group, and the whole scenario gives us an idea that it is an endometrioma. So the patients who have endometriosis will always have a CA-125 on the higher side, not very high, but it can be on the higher side. But the ovarian picture of ultrasound is clearly a case of endometrioma. Because she's a premenopausal lady, so we'll not do oophorectomy in this case, but yes, because it is more than 3 centimeters and causing symptoms, severe symptoms to the patients, it requires a ovarian cystectomy. Sorry, 54 years old with the 2 big sons is referred for ultrasound done. Follow-up as she was an ultrasound done before 4 months, which a simple ovarian cyst was seen. The ultrasound now shows the same picture, almost the same picture, little decrease in size, and her CA-125 is 8. She has otherwise no complaints, asymptomatic, fit and well. Now, post-menopausal lady with a simple ovarian cyst. On the first follow-up, she has the size is little decrease, but the cyst is there and the CA-125 is 8, but the RMI score is still, because it's a simple ovarian cyst, this is 0. And she is asymptomatic. So what we can do, we can call her once more after 4 to 6 months. Okay. And see how does she respond. So repeat TVS will be required after, because today when she has done the ultrasound, it is this almost the same findings as before. So she requires one more follow-up at 4 months. After that, you will assess again, you will do a repeat ultrasound and CA-125 after 4 to 6 months. So after 1 year of follow, if the symptoms still, if the condition still persists, then it is an individualized approach we have to do. Okay. So in the postmenopausal lady, if the patient has simple ovarian cyst, which is less than 5 centimeters in size, asymptomatic, unilocular, unilateral. Okay. So these patients, and the RMI is less than 200. So these patients can be kept on follow-up. 2 follow-ups can be done after 4 to 6 months apart. Okay. And after 2 follow-up, if the cyst persists, if the patient has any change in symptoms, cyst increases in size, CA-125 increases, then we have to do a surgical option. If there is a persistent, then we have to do a individualized approach. If everything regresses, then we can discharge from follow-up. Again, there is a woman with constitutional symptoms of abdominal distension. Ultrasound shows an ovarian mass with no capsule breach. Retroperitoneal lymph nodes are involved. Ultrasound biopsy confirms malignancy. She is at the cancer center. What to be do? Very important. Cancer patient needs to be do a surging laparotomy. So just to summarize all these three questions, postmenopausal ovarian cyst, when we measure, if there is an ovarian cyst, first thing in ultrasound, first we measure the CA125 and calculate an RMI score. If RMI is greater than equal to 200, she goes for a CT scan and an ongoing referral to the cancer center. Okay. If she has a RMI of less than 200, we see if the patient has less than 5 centimeters cyst, simple, asymptomatic, unilateral, unilocular, put her on follow-up. If anything is not this, that is more than 5 centimeters, symptomatic, bilateral, bilocular cyst is there, non-simple, then always consider a surgery. That is bilateral salpingo-oophorectomy in the postmenopausal age group. So 28-year-old para-1 woman with a history of PCOS syndrome presents to the gynecological emergency unit with 6 hours history of severe intermittent left leg fossa pain, nausea, vomiting, low-grade pyrexia. Transvaginal scan suggests that it is an edematous large ovary, abnormal blood flow, white blood cell count is increased, CRP is increased, and she has been fluid resuscitated and has received intramuscular opioid injection. And what is the ideal management for her? So if you can see, the patient has a symptomatology that she is basically a case of ovarian torsion. Okay. Ovarian torsion with the little increase in the markers, not much increase, because WBC is still okay, not very high. So first, for any patient with ovarian torsion, what do? We always do a diagnostic laparoscopy and preferably do a detorsion. Even if it is a purple looking ovary, gangrenous variety, and the patient is not in sepsis, then you can detort it and wait for 2 to 3 weeks before you undergo the patient to undergo the cystectomy. So interval cystectomy is preferred in these patients. Okay. Immediately we don't do the cystectomy because you will lose more of the ovarian tissue because it is edematous right now. So the next question is a 32-year-old 6 weeks pregnant patient who comes to an emergency department with the complaint of spotting per vaginal on transvaginal ultrasound. There is an ovarian cyst with a ground glass echogenicity and no other problems, no papillary structures. And is suspected to be a dermoid cyst, and they are asking you the what should be the next step in management. So for the pregnant patients, if there is a benign looking cyst, you can rescan after 4 to 6 weeks. Okay. You can see whether it is increasing, decreasing, is there any other complaint, any change in the features or not. So after 2 months, you need to analyze it again. So for the adnexal masses in pregnancy, if it is an acute abdomen, you can consider surgery. If it is an asymptomatic benign simple cyst of less than 5 centimeters, do nothing. Simple cyst of more than 5 centimeters or complex cyst with no other complaints, then you can rescan after 4 to 6 months and the patient lies in this category. And any indeterminate or suspicious features of cancer require the further imaging by MRI and the tumor markers. Next patient is a 34-year-old nullipara, menstrual nullipara, HMB, PCOS, BMI 34, and on histopathology, if you see, there is something which is known as complex atypical hyperplasia, crowded glands, back-to-back fashion, minimal stroma, big nucleus. Further discussing about the management, and she wants to retain the uterus for the fertility purpose. Now, these patients you can treat with the medical management. Ideally, the patients with atypia, endometrial hyperplasia with the atypia, 100% should undergo surgery. But if the patient is waiting for her fertility, so you can start their management with the medical management, that is LNG IUS, and do a biopsy after 3 months. If one negative biopsy they receive, they should refer the patient for the ART center. Okay, so there is the aim to achieve the disease regression in at least one endometrial samples before attempting to conceive. Next patient is a patient with the 34-year-old incidental finding of an ultrasound showing a ovarian cyst of 30 millimeters in size, that is 3 centimeters. So for the premenopausal age group, if there is a simple asymptomatic cyst which is 3 to 5, less than 5, then you do nothing. Okay. 5 to 7, you can do annual follow-up with them, and more than 7 requires an intervention. So this is true for the simple asymptomatic ovarian cyst. Then 48-year-old women, irregular heavy bleeding, endometrial biopsy confirms endometrial hyperplasia without atypia, normal BMI, no past medical history. There is a laparoscopic sterilization at the age of 35. LNG-IUS is inserted for 6 months, after which it was removed. Endometrial biopsy at that time was normal. Subsequent biopsy 6 months later was also normal. The woman continues to have ongoing bleeding. What is the appropriate management? Now, whenever the medical management, that is LNG-IUS, is given to the patient for endometrial hyperplasia without atypia, they do 2 biopsies 6 months apart for being negative. Okay. If they are negative, then they are discharging the patient from follow-up. But here the problem is the patient is still having ongoing bleeding. That means something we are missing in biopsy. Okay. So these patients in whom, despite of medical management, despite of endometrial biopsy being normal, if there is having a high ongoing bleeding, they are the candidates for the surgical option, that is offer hysterectomy. Okay. So hysterectomy is offered for the patient of endometrial hyperplasia if there are atypical features, if there is no disease regression after 12 months, there is a relapse, there is persistence of bleeding symptoms, or if the patient declines the surveillance. A 32-year-old Jehovah Witness, menorrhagia with the listlessness of 18 months duration, 3 vaginal deliveries. She has been sterilized in the past. Periods are so heavy that she suffers giddiness, and she has to take time off work. Leave from work. On examination, she is pale with otherwise healthy. No abdominal pelvic mass is there. There is an abdominal pelvic mass which is extending to umbilicus. Irregular form in consistency. Ultrasound confirms multiple uterine fibroids, intramural in nature. Ovaries are normal. Or she has tried all medical management, has not helped her. What is the most appropriate treatment option? So these patients in whom hysterectomy, blood transfusion can be an issue. So these patients ideally, because medical management has failed in them, they are ideally the candidates where the minimal surgical options like UAE can be offered to them. Okay. So she has and provided you before UAE, you have to confirm she has completed her family. Okay. So these patients, and total hysterectomy will be a problem for her, because first of all, she is very young, and second of all, she is a Jehovah Witness where the hysterectomy might bleed a lot, may require blood transfusion because of multiple fibroids, which she won't agree. 56 years old para 3 diabetic postmenopausal lady underwent evaluation for postmenopausal bleeding. She has endometrial hyperplasia without atypia. BMI is 40. She is opting for the oral progesterone as treatment. Underwent 2 endometrial biopsies 6 months apart. Both were negative. What will be the further management? So I have told you earlier also, any patient who has been treated with oral progesterone for endometrial hyperplasia, after 2 negative biopsies, she has to be put on endometrial biopsy done annually. Okay. Or if the patient was treated with LNG-IUS, but her BMI is 35 and above, those patients also, after 2 negative biopsies, annual biopsy needs to be done. Otherwise, in general, LNG-IUS treatment and 2 negative biopsies 6 months apart do not require any follow-up. 25-year-old patient presents with the right side pelvic pain more than 1 year. Ultrasounds is arranged. She has a well-defined 5 centimeter mass with mixed decos. There is no fluid in pouch of Douglas, cul-de-sac, and sonographic image shows this picture. So you can see that the patient very clearly has some lesion in her ovarian cyst, which is basically a hypoechoic mass. Okay. And likely most common condition resulting in this is a dermoid cyst. Okay. Benign cystic teratoma. So patients in whom there is a diffuse or partially echogenic mass with posterior sound attenuation due to sebaceous or hair within the cavity, an echogenic interface at the edge, mural hyperechogenicity, echogenic showing the calcification, presence of fluids, flea fluids level 5, or multiple thin echogenic bands. They are all the features of the dermoid cyst on ultrasound. Okay, and mostly these cysts are uniloculars. 36 years old, has ultrasound showing fibroid. She is concerned about cancer and wants to know the probability that this fibroid be a cancer. So the patients in whom the fibroid is there is very rare that they changes to sarcomatous change. Okay. However, if they ask you the percentage, which is 0.1% cases, it can go into the sarcomatous change. Okay. 45-year-old presented with the gynae clinic. She is having severe dysmenorrhea, not responding to medication. She wanted a permanent treatment. She underwent laparoscopic hysterectomy. Histopathology shows asymmetrically enlarged uterus and globular due to myometrial hypertrophy reflected by the thickened myometrium. Trabeculated cut surface with ill-defined hypertrophic whorls of smooth cell metache like gray foci of endometrium is seen. Blood-filled cystic spaces are seen. So I think everybody has a correct clue. Severe dysmenorrhea with the these findings in the myometrium is very clear that it is a kind of adenomyosis. So thank you, everybody. I hope the session was helpful, and yes, we'll be bringing more and more to you under StudyMEDIC RRR series for EFOG. So good luck to everybody. All the best, and thank you so much.